invite Dr. Shravya Choudhary for the paper Late Diagnostic Revision to Tubercular Colitis in Patient with Recurrent APPM PPE.
Shravya.
Yeah, she has.
Hi. Good morning, everyone. So I'm Shravya Choudhary BALLA, Uveitis Fellow at LV Prasad Eye Institute, and I'll be presenting on late diagnostic revision to tubercular choroiditis in patients with recurrent AMP. So we all know that AMP is an inflammatory eye disease that affects the inner choroid and the outer retina. It has been first described by Professor Gass in 1968 as these multiple discrete creamy yellowed lesions that you're seeing in this fundus image. At that time, the primary pathology was thought to be at the level of the RP, and it was classified under the spectrum of white dot syndromes. But later on, it has been reclassified as choriocapillaritis. So the pathogenesis is not known. A pre-existing autoimmune and autoinflammatory disease are known. Positive TB immunological test has also been reported, and HLA-B7 and HLA-DR2 has also been reported. In addition, numerous cases have also shown that there is an immune-driven nature, because post-immunization also AMP is known to occur. So with this, I move on to the study. The purpose of the study was to investigate recurrence patterns of AMP and its diagnostic revision to ocular tuberculosis. So we retrieved records from 2014 to 2024. We included all patients who were diagnosed as AMP and had at least a clinical examination of follow-up of 3 months. We excluded patients with incomplete medical records, and descriptive analysis was done. We used the Fisher extract test to see if there was any statistical significance. So the initial presentation, treatment and follow-up, recurrence, clinical phenotype of recurrence, investigations, treatment and follow-up were noted. A total of 40 patients met the inclusion criteria. The cohort had a mean of 33 plus or minus 9 years. And we saw that recurrence was noted in 18%, that is 7 patients. And these 5 patients were reclassified as ocular. If you look at this table, we can see that 5 patients were reclassified as choroidal granuloma, and 1 had serpiginous-like choroiditis based on the lesion morphology, along with laboratory test and a chest X-ray or X-ray wherever required. Out of the 7, 2 were treated with only oral steroids, and the rest required anti-tubercular treatment. So this, I would like to discuss one case. It is a 48-year-old female patient who presented to us in 2014 with an initial presentation which looked like AMP. We had treated her with topical and oral steroids alone. 3 weeks later, her vision had improved. You can see that the lesions are resolved. However, 4 years later, she came back with a drop in vision. There was a choroiditis lesion that you can see along the inferior temporal arcade. The MON2 was positive. The quantiferon was negative. We treated this patient with ATT and oral steroids. She was better. However, 2 years later, she came back with a resolution of the TB choroiditis at the same location. And this time, we also performed a PCR, and the PCR was positive for Mycobacterium tuberculosis. So now going back to our study, a Fisher extract test was performed to assess the association between the recurrence of AMP and the diagnostic revision, and the p-value was found to be statistically significant. So it is very fascinating to note that even in the 3 cases that were described by Professor Gass, case 1 and case 3 also had a positive tuberculin test, and case 2 had a positive family history. The father had pulmonary tuberculosis. And literature also shows that some cases of AMP have been reported in patients with positive tuberculosis tests, especially the first, which was published in a British Journal of Ophthalmology. This patient had pulmonary tuberculosis, and another case report that I've mentioned here. So to conclude, AMP may be the initial presentation of ocular tuberculosis, especially the recurrent cases, and all AMP should be closely monitored for recurrences even after initial response to corticosteroid therapy. Thank you.
Nice. So what were your basic treatment for a patient with AMP? What is your treatment basically?
So I know that literature says that even if you observe it, it resolves. But
how are you treating?
We are treating all our patients with oral steroids.
Oral steroids. What duration and what dose?
Visalone, we taper it from 50, maximum 60 kg based on the patient's body weight to at least 6 weeks.
And then they all resolve over that 6 weeks. So if they're not resolving, then you're thinking of this.
Yes.
So do you feel that there's a confluence of ampy and serpiginous like choroiditis? You feel that there's a, now it's coming closer to
Yeah,
that?
maybe
like,
because the pattern also is kind of
Yeah.
a little.
What do you comment about the treatment modalities for both the things? Because it looks like a continuous spectrum. For in serpiginous choroiditis, you would not leave it for 6 months. You would treat it for longer. Even in VKH, you would treat it for longer. So how about this? Are we sticking to 6 months or less?
I think 6 months at least, and follow up the patients closely, so that for any recurrences.
So your
What?
take-home message would be after revising this, your diagnosis were revised to TB. So would you prefer to do a MON2 first, then starting steroids before,
Yeah, definitely. I think we screen the patients, do Monto and quantiferon, and then
and then only start for all APMPP cases?
Yeah, so now you're screening all your APPMP for TB, is it?
yes,
Am I
we are
right?
screening them for.
Yeah.
So would you follow the same pattern which was recommended earlier in the talk, like the 3 tests, HRCT chest, interferon gold and MON2, or only MON2 you will?
No, we do. If there's a suspicion for TB, then definitely we do Monto, quantiferon, and CCT chest.
And what is your cutoff time when you suspect patient may be suffering from tuberculosis? Because you're already treating patient on the line of APB.
I'm sorry, can you repeat that?
You already treating the patient on the line of APME. When do you consider that cutoff line for you when you think that patient may be suffering from tubercular antigen, and then you are supposed to go for diagnostics?
In this study, only the patients who had come back with a recurrence, we had seen that there was TB, but this was a retrospective study. So
what
going
is the
forward,
cutoff line? Suppose you already put the patient on the treatment. Now, when do you think, okay, now this is time I'm supposed to move on to my second strategy?
maybe if they're not responding.
That's what. What's the duration for you? Not responding, maybe months or
So
years.
for
or what
AMP,
is
I
it?
think 2 to 6 weeks they should resolve. But if between 2 to 6 weeks they don't resolve, then
So
definitely.
that's a standard time which you're giving
Yes.
for all the patients, right? Not before that you are thinking of it.
I think we should add it as a part of workup of MP patients. Tuberculosis should be added. Normally, what we were doing was MP, okay, let's not investigate. Now we should.
Because same way, if it's get delayed, again immunomodulation will come.
True.
We don't want that,
Yeah.
right?
No, but one point I want to bring out, since I'm a senior guy on this, I think JDM gas had found everything that is to be known in macula before OCT came or anything came. I think, I don't know, he had some OCT eyes, just want to bring out that point, yeah. Thank you so much.
Thank
you.
Thank you.